So what is the impact of pressure injuries? Well, when we look at it, if you're in the United States, we have about 2.5 million people treated annually in acute care for hospital-acquired pressure injuries. And in the last international pressure injury survey, in the medical surgical areas, the prevalence was about 1.87%, and the incidence was 5.85% in critical care. Global ICU pressure injury rates. This was done by the Decubiti pressure injury study, which was a 1-day point prevalence that was done around the world. And you're looking at incident rates in critical care between 15 and 16.8% and prevalence between 25 and 27%. Global hospital-wide, I dug deep to try and find the data, 5.4% on the incidence and prevalence about 12.8%. So slightly higher worldwide. Needless to say, most severe pressure injuries are in the buttocks and the heels. So where does that tell me they are hanging out? In the bed, on their back. As a part of it. So, and this is in study after study after study. People die from these pressure injuries. There's significant pain and suffering, and there is, in our elderly population, there's a twofold increase just by being greater than 65 years of age for the development of a pressure injury. So this, you see the pain and suffering and the amount of injury that is taking place. What is it costing our healthcare systems? Well, and no pun intended, this is a cost analysis you can take to the bank because it was done by a health economics individual specialist on this. Cost of a stage one is roughly, stage one, stage two is roughly around $3,000. When you move to the stage 3 and stage 4 or unstageable or DTIs, that moves up to 71 to 127,000. Now in the United States, we're a fairly litigious society, and so there are about 17,000 lawsuits annually with the average payout between $250,000 and $500,000. And we know if we were able to provide the standard of care with those prevention strategies, it would actually cost less money than to treat the pressure injury and deal with the quality of life factors. So in the United States, it's costing our health system about $26 billion per year. So it's important to have a comprehensive pressure injury prevention program with risk assessment, skin assessment, support surfaces, repositioning to offload those bony prominences, prophylactic use of a dressing, heel elevation, and nutrition. But everything starts with a good risk assessment and skin assessment. So I'm going to talk about assessing the skin and how important early detection is, because when we detect things early, we can really hone in on those people that the offloading is critical, and they may need to be offloaded more frequently or never put in that position where their area of risk or injury has been identified. So in terms of assessing the skin, what does the science tell us? And this comes from the SPIP, from the National Pressure Injury Advisory Panel, which comes off based off of the guidelines to assess the skin. Comprehensive visual palpation, and you're going to learn more about that. And this is done upon admission and Q shift. And every shift, we need to be assessing under the nasal cannula, under the devices. If they've got a splint to hold their IV, we need to look at all of those devices. And the heels, because they are massively susceptible, we need to make sure we're taking those TED hose off if you're still using them and inspecting the heels Q shift. In people with darkly pigmented skin or people of color, one of the things you can do to improve your assessment is improve the lighting and moisten the skin, which helps augment some of the visual inspection. And then it's really important to consider enhanced skin assessment methods. And that would be subepidermal moisture assessment or thermography and using a standardized different skin tone chart so that you know what you're looking at as a part of that. So some of the challenges we face right now with early detection, identifying risk with standard tools, do they work for all populations? Now, in my perfect world, because that's where I live, and I want everybody else to hang out in my perfect world too, is if I'm using a risk assessment tool, I want to make sure it's reliable and valid. And in the United States, we use the Braden risk assessment tool the most. But for me, what is more significant of using that risk assessment tool is to actually use the subscales because they're far more predictive and they can drive interventions based on those risks. The visible and tactile skin assessment is considered the gold standard. You need to do it absolutely. But pressure injuries often develop in the deep tissues first, so we don't visually see it. It may not feel different, may not have a different color, may not have a different temperature. And so it's really clear to understand that visual assessment is not sufficient to detect the damage until the skin tone changes, which is too late for us to do anything to potentially reverse the injury. So visual assessment is also challenging with darkly pigmented skin, like I shared with you. So we do have some data on that. This was a study looking at pressure injury rates in darkly pigmented individuals from 2008 to 2012. They had there was about 670,000 cases reported with stage 3, stage 4, higher rates in men, higher rates in African Americans, and 2.4% higher rate of pressure injuries compared to all other races with a darkly pigmented skin, as well as having a higher mortality rate. So what the data is showing us with different colored skin or different pigmented skin other than a more pale pigmented skin is that we're likely to miss stage 1 and deep tissue injuries. That's what the science is telling us. And that's what this study told us. Stage 1 and deep tissue injury are the toughest. This was 96 African Americans with 274 pressure injuries. 32% were stage 1 and 67% were DTIs. Literally those getting missed as a part of it. And so difficult to see. And there was a large variation in the presentation. 70% had some purple, 14% had some gray, 10% had some black, some brown. So it really made it difficult to be able to assess the presence of a DTI. So really the concept of these enhanced assessment tools is getting under the skin, being a detective, using technology for earlier detection of pressure injuries. So let's talk about what is happening underneath the skin physiologically when the cell has sustained pressure, shear, and tissue deforming. So let me get that. So here's our cell damage. So we start to have some cell damage because of the pressure, because of the shear. We then have some cell death. Then some inflammation occurs as a result of it, and we have leaking of fluid out of that as part of the inflammatory process, which then leads to edema. And that edema increases the interstitial pressure, which then squeezes vessels around, so causes further ischemia, leading to further tissue death. And so you've got this whole leading to tissue deformation. So the concept here is damage can occur 3 to 6 days before you see the breakdown on the visible skin surface. So we can use the opportunity to capture early when edema is happening to be able to identify those patients at risk. So clearly this piece of it is not visible. This isn't visible unless you use technology. And over here it becomes visible, but it's too late. So this is then a breakdown of going the microscopic to the macroscopic edema. So when you have this damage and you have a reaction that occurs that says, let's get more blood flow to this area. The blood flow results in the inflammation process, increased permeability, fluid released into the tissues. That additional fluid and that inflammatory process attracts the WBCs to the site of the injury. It can then lead to an inflammatory response if it goes systemic. So not just a localized inflammatory, this can also move to a systemic, and this is where you may also get sepsis, higher levels of white count, higher levels of so the WBCs, the fever, and the other signs and symptoms of sepsis. So the guidelines, the 2019 guidelines, and this part of the guideline, the skin assessment hasn't been, the update of it for 2025 hasn't been released yet. I keep on checking the website. It'll be released between now and I believe November. So it recommends consider using a subepidermal moisture edema measurement device as an adjunct to routine clinical assessment. And the strength of the evidence is a B2. And the strength of the recommendation would be classified as nonspecific. And then it also says when assessing darkly pigmented skin, consider assessment of skin temperature or subepidermal moisture as adjunct strategies as part of your assessment. So you saw that I mentioned thermography. This is an example of being able to identify, this is a visual and infrared that captures present on emission where the DTI was not necessarily visible to the naked eye, but you could clearly see the significant temperature change that was taking place. So the detection of pressure injury by identifying early temperature changes in the skin can indicate tissue damage when we see it. The infrared imaging, it emits an infrared radiation, which is captured by the thermal imaging camera that then gives you this image as well as the temperatures. And the areas of potential injury may appear cooler on the thermal image due to impaired blood flow going to that area compared to, and you always do a comparison to healthy tissue. And you can see that 0.1 degrees centigrade cutoff temperature determined pressure injury risk. So you're going down, here is your cool colors. And roughly the science is showing that this temperature change shows up about 48 hours sooner than the visual that you and I see. Now, the other technology is subepidermal moisture monitoring. So what does that do? Let's walk through it. The moisture level of the subepidermal tissue is measured using an electrode structure placed on the surface of the skin. Low amplitude signals are used to assess the level of fluid in the epidermal and the subepidermal tissue. And then the fluid in the tissue, as I shared with you previously, is part of that inflammation process that is happening as a pressure injury is beginning. And the amount of fluid is an early indicator of this tissue damage.
Oh, that's great, Kathleen. Let's show the global audience how to do an SEM measurement.
So now we're going to show you how to scan a patient. In this first scenario, we're going to scan the left heel. So we select the left heel, and the scanner is now ready to use for your patient. Always ensure the surface of the skin being assessed is clean and dry before you start the scanning process. Apply the sensor head flat against the patient's skin in the area to be scanned with sufficient pressure until the scan is triggered. When a scan is triggered, the scanner will flash blue and emit a short audio tone. Here you can see we're scanning the back of the heel, and you will see the blue flash as the scan is triggered. Next, we'll scan the lateral side of the heel, and it's very important when you remove the scanner from the skin that you lift it cleanly off and do not drag it. Next, the medial side of the heel, and again you'll see the blue flash as the scan is triggered. And finally, the heel pad, which can be omitted if the patient has heavily calloused heels. In this scenario for the left heel, we've now completed our 4 scans, and the delta reading is shown in the large circle. You can see that the delta reading is below the 0.6 cutoff and is colour-coded green, which suggests for the left heel, the skin is at reduced risk of pressure injury. In our second scenario, we're going to scan the sacrum. Again, you select the body area and the scanner is now ready to use for your patient. You complete 6 readings at the positions shown in the figure to the right. Our 6 scans are now complete. And in this scenario for the sacrum, you can see that the delta reading is above the 0.6 cutoff and is colour-coded orange. This suggests that the skin at the sacrum is at increased risk of a pressure injury, and you should start or alter your preventive interventions. To review all your readings, press the body location screen and make sure that you plan to document them or to upload them to your electronic health record by placing the device into the charging hub. When you've finished scanning your individual patient, make sure that you remove the single-use sensor and clean the device thoroughly according to your hospital protocol.
Kathleen, can you share with the global audience how you analyse the SEM measurement numbers and figures?
So if I get a subepidermal moisture reading of greater than 0.6, it's considered high or abnormal. And I obtain multiple measurements in the same area to be able to get what is called the delta change, to be able to tell me if I am in that greater than 0.6 range, and that tells me I got something going on. And I will share with you, I know organizations in my country are using this in emergency rooms to evaluate present on admission, that there is some injury taking place already before they ever entered the building or the hospital. So biocapacitance is an electrical property of the tissue that varies with the amount of interstitial moisture content. Remember, we talked about how that moisture content develops. The greater the interstitial moisture, the higher the biocapacitance of the tissue is. And the higher that is, this is then interpreted by the scanner. So you can see the scanner. It's pretty easy handheld device. And when we get a SIM delta from multiple readings greater than a 0.6, it suggests the increased risk and that there's likely going to be injury present. So this was a systematic review of the literature of 17 studies looking at subepidermal moisture evaluation to identify pressure injury development. And what they were able to identify in this, that there was a consistent abnormal deviation in the SIM measurements that corresponded with the evidence of a visual pressure injury development. And what excited me about this is that the detection by the SIM measurement occurred roughly about 4.5 days before the visual showed up. So that gives me good warning to be able to offload that pressure significantly, but also that concept of present on admission. So PI development was clearly earlier than visual inspection. When this was used, There was a 93% reduction in pressure injury rates when staff responded with preventative strategies, augmented preventative strategies to this abnormal SIM measurement. The range of sensitivity is about 48 to 100%, and specificity ranges between 24 and 83%. So when we look at this, this is the way my brain thinks. I want to detect early. So literally, the SIM delta is giving me 5 days earlier in my detection of at risk or the beginning development of injury. And then it says, if I have this raised SIM, it's like that pre-stage 1 we talked about, and I'm going to offload or not even put the patient in that area or positioning. And we want to treat those raised levels of SIM because when we do, we can achieve a 3-fold reduction in pressure injuries. And then ultimately, this can help us prevent pressure injuries by putting those strategies in place and knowing and continuing to measure and identify risk for our patients. So I want to thank everybody for their time and attention.